We are in the midst of global financial crises, experiencing the sort of economic inequalities that we haven't seen over the previous decades. We're also experiencing a number of policies that are being implemented globally to which we have little access as citizens and as participants. Examples such as the Trans-Pacific Partnership that are determining the new realm of global trade within the context of Asia are being carried out in closed doors with limited access among citizenry to the kinds of information that go into these agreements. I will therefore, within this context, propose the idea of information inequality, defining information inequality within the realm of information that relates to policies and agreements that have impact on human health. The traditional definition of health information typically is information that focuses on individual behavior and individual lifestyles. So we look at information on healthy eating, information on exercising, information on taking the right medicine. Much of this focus being on improving or changing individual behavior, which will then allow us to improve our health outcomes. I will, however, argue that large pieces of information related to policy making are typically the kinds of information that we do not consider within the mainstream health communication literature. For instance, we do not really often look at information on health policies or information on economic policies that have tremendous impact on human health. Take the Trans-Pacific Partnership as an example, particularly as it relates to the health elements of the partnership. As the TPP agreements or the Trans-Pacific Partnership agreements, as they are referred to, are starting to be emboldened as policy frameworks for global trade, one of the things that we are starting to recognize are the ways in which these agreements then will threaten human health. Take the example, for instance, of tobacco policies. Within the realm of TPP agreements, corporations, for instance, tobacco corporations such as Philip Morris will have the ability to sue nation states, appealing to the notion of free trade, and at the same time, therefore, undermining the ability of nation states to regulate the tobacco industry within the context of an appeal to human health. This kind of information, though, information that relates to policy making, information that is connected to trade agreements, is a sort of information that is not available to your everyday public. Much of the agreements, for instance, are being carried out within closed doors with limited access to information among the public to what is actually included in these agreements. Moreover, how the decisions are being made regarding these agreements is also pretty undemocratic, meaning that there is very little public participation in the decision-making processes building up to these agreements. So I'm really making an argument at two levels. There is limited public access to the information about what is in the agreements and what are the health implications of these particular policies. And two, there is a limited access to actually the decision-making processes and the decision-making platforms where these agreements are being debated and then decisions are actually being made. I believe that both of these elements have very important health consequences that are not being really debated about, that are not being argued about, simply because we do not have access to information about the agreements themselves or the decision-making processes going into the agreement. This perhaps is a strong example or an excellent example of how much of health communication today takes place within expert realms of elite structures with limited democratic opportunities for participation. An examination of questions of health inequalities, therefore, fundamentally has to look at the inequities in decision-making processes, inequities in access to policy-relevant information. We need to ask questions such as who does and does not have access to information about what is in the TPP agreements. We need to ask questions about who is participating in these decision making processes. As we do that, then we need to closely examine the ways in which these decisions are being carried out in undemocratic ways, in elite driven, expert driven ways that fundamentally threaten the very notion of participatory communication and democratic communication. To address inequalities of health more broadly, I would suggest that we need to fundamentally start thinking about ways in which the inequities in communication, the inequities in information access get addressed. So, more broadly, as I think about how the culture centered approach discusses the ways in which information inequalities and health inequalities can be addressed, we need to start considering how to build democratic platforms where more communities, particularly communities at the margins, will have access to complex policy information, and then more importantly will have access to the decision making processes where their voices can be heard and where they can play important roles in shaping what these policies actually are.